Well, we talked about holes in the skull last time. And
Yeah.
today we got kind of a continuation of that.
Talking about lobotomies, not labiotomies, but lobotomies.
Gosh. Those are not even close to each other. I don't know how you get those confused.
So I'll tell you why, I think. Because I had never heard of the Kennedy sister story whatsoever. And the first time I ever heard about it, once again, haven't heard of a lot of things. First time I ever heard about it, I remember someone saying they were worried about her like getting pregnant and the way it would look on like the family and all of that. And so they decided to do this lobotomy. And I think in my head, it just went straight to like, well, I guess if you don't enjoy sex anymore, like you're not going to have sex and get pregnant. I think that's where it came from.
that's a thing, but like that's just crazy.
Crazy stuff.
Yeah. So
today,
let's get into it.
The lobotomy legacy.
Yeah. Wild. Okay.
Welcome, Cadaver Crew.
Get your dark little minds right and settle in.
Class is in session and the cadaver is already on the table.
I'm B.
And I'm Sam.
And this is
the Cadaver's Lessons.
Alrighty. Quick vitals check. It's early.
It's early.
I regret this.
100%. Yeah, it sucks when you have a kid and you have to wake up even earlier to make sure like their stuff is together before you can leave. Yeah, so it might take a while to get really into the banter and everything, but we're going to do our best. It's going to be great.
We had some caffeine, but not nearly enough.
No, I should have shotgunned Celsius before coming in. Yeah.
Sponsor us.
Sponsor us, please.
Okay. Well, on that high note, let's jump into it. Okay, so we're going to talk about lobotomies, and this really goes in connection with our previous topic.
Yeah.
One really flows into the next because we talked about like the Renaissance paintings and the stones of folly and removing madness from the brain, right? Through the hole within the skull.
Yeah.
And that's kind of where lobotomies take off. This idea that you can remove portions of the brain in order to remove madness.
Wild stuff.
Yeah.
I imagine if we just did like a frontal lobe lobotomy for everyone and then just like reconnected it at 25 and it was fully formed.
I don't think that's supposed to work. But yeah, during this time, obviously throughout all of mankind and throughout history, the mentally ill have been treated as pariahs. Right? They're placed in crowded hospitals or committed to insane asylums. And if there are any kind of criminal charges associated with them, they're just thrown in jail or executed. So that's why later on in history, where people are like, oh my gosh, why is there so many people that are crazy? And it's like, no, there was always that many people. They were just murdered or killed.
You ever heard about the Dorothy Dix Hospital in Raleigh, North Carolina?
I have.
Yes. I don't know the full story of it, but I remember hearing about it when I was younger. And basically it was a whole hospital for the mentally ill. And then one day they didn't have funding anymore and they just shut down. And they didn't find like new places for these people to go, anything. They just like took them out to the streets and they were like, be free, friends. Mm-hmm. And then after that, Raleigh was like, what is up with this homeless population? What's going on? Oh, you mean you had them all in this hospital and then you decided you weren't going to fund it anymore?
Yep.
Yeah, this is what I think about with this.
Oh, yeah. And that's actually what we're going to talk about a little bit later is like hospital populations. And then government had passed a bill in the 1950s, 1960s that canceled all asylums and institutions like that and essentially put them back onto the streets. And what that did is had a spike in people just being out in the open instead of being hidden away within asylums, which either way is sad and
super sad.
Disheartening and shows a failure on,
society's
ability to take care of those who are vulnerable. So for instance, actually in 1247, St. Bethlehem Hospital in London was the first institution dedicated to the care and treatment of the mentally ill.
God, that's so long ago.
I know it's hard to believe because here in America, things things are only like so old.
Yeah.
Because America is
1776, baby.
Yeah. What, like only a couple hundred years old, you know?
Yeah.
Well, there was this part of the world that
Before
is
us.
before us that was much, much older. You hit the Renaissance, you see people become interested in removing portions of the brain and drilling into the skull in order to cleanse the brain or get rid of stale blood and portions of the brain that might be causing madness. And then you see the beginnings of asylums and institutions that are built for the sole treatment of the mentally ill.
Yeah.
And there are records and drawings and paintings from St. Bethlehem Hospital where there's actually trepidations happening.
At the hospital.
At the hospital.
Yeah.
In unsanitary conditions without proper sterilization or anything like that. Just on the floor and happening with people who cannot represent themselves.
Yeah, they don't have decision-making capacity to be able to say yes or no and like actually understand the risks versus benefit of this.
Right.
Yeah.
Yeah. So in general, these hospitals were poorly prepared to cope with the mental and social problems and remained overcrowded, which will later impact the reasoning on why lobotomies became so popular. They were a hit.
Yeah.
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 So before we jump into lobotomies becoming the way to go,
the
fad of the 1930s and 40s, let's talk about where the idea of removing portions of the brain or damaging portions of the brain could change behavior.
Yeah.
So we knew people were trying to remove madness, but one of the cases that kind of kicked it off was the American crowbar case.
Yeah. And I saw this case and did not do research on it, but saw this case when I was doing like modern research and just wild.
Wild, right?
Wild.
I actually learned about this when I was studying psychology in college and getting my degree. It's like classic case to talk about in psych because it's the best, one of the best recorded incidents where somebody had damaged multiple areas of the brain were damaged.
Yeah.
And total behavioral change, personality change.
Yeah.
Completely. So here's what happened. There's two kind of main concepts and ways of understanding brain anatomy and the concept of cerebral localization.
Yeah.
And cerebral localization is the determination of specific sites in the brain responsible for specific nervous functions like language, vision, and movement.
Mm-hmm.
And so first was the study of removing tumors or the act of a tumor, what it's doing to the brain, and the operations for their removal. So you have a brain tumor, it's recognized, and then you get that removed and finding the effects of that removal.
And like just, you know, some brain tumors are big enough that they're compressing and we can already see some of those cranial nerve palsies.
Mm-hmm.
And so I'm sure people didn't understand it at the time, but like someone starts having blurry vision or like some of these other signs and symptoms and they don't realize it, but we're already seeing the effects.
Right.
Yeah.
Yeah. So that was one. It was the study of the tumors. It was kind of the way that we see the understanding of brain anatomy and the concept of, okay, this part of the brain is attributed to this function.
Yeah.
Right. And then the second was observation from dramatically altered behavior in the case of a very traumatic brain injury to the frontal lobe.
Yes.
Which is what this is.
Yes.
Which is what the crowbar case is all about. Which I don't understand why they call it crowbar case because it was not a crowbar.
No, I thought the same.
Yeah. Yeah. Interesting. People are just like, it's a bar. Call it something. And so what happened was in 1848, Phineas Gage, at the age of 25.
I mean, it's 1848. We're hitting our midlife crisis.
Yeah. Midlife. Right. He was a construction foreman at the Rutland and Burlington Railroad and was severely injured when helping construct the railway line. Quick background, a tamping iron is a heavy iron rod, often with a blunt and tapered end, used historically in mining and construction to compact or tamp explosive powder and tamping material like sand or clay into a borehole to direct the force of a blast.
Yeah. And now in high school, I had to use it to tamp together my catcher's box after every game. The exact same kind they used back in the 1800s.
That's probably exactly relevant and unsafe.
Yes, precisely.
So what happened was Gage was using a tamping iron as the foreman, and a premature explosion propelled the tamping iron, which is a long bar measuring 3 feet 7 inches in length and 1.25 inches in diameter. And it went through his head.
Like through the eye socket? Like how did it get? This is what I couldn't figure out.
Here you go. 13.25 pound rod
Imagine carrying that around.
Is first carrying it around and then it
Yeah.
getting blown into your head,
Yeah.
right? Penetrated his left cheek,
Okay.
traversed the midline, the left frontal lobe, and exited the cranium just right of the midline near the intersection of the sagittal and coronal structures.
Wow. Okay.
So that's essentially left cheek through the top
Wow.
right of his skull.
Wow.
Yeah. And first of all, he survived.
Wild. That's to me actually the wildest part about all of this is that you think about how thick that is, how heavy that is, and just the fact that it somehow didn't hit enough important structures, and like the swelling didn't cause a brain hernia, like all of this stuff, right? He survived.
Right, yeah. He survived, but there was extreme mental and behavioral changes. So before this incident, he was described as motivated, energetic, capable, friendly, a conscientious worker. And then after, he was described as, and I think it's so funny because some of these words, I'm like, of course this happened in the 1800s. Like, why can we using these? Obstinate, irreverent, irresponsible, socially uninhibited individual. And I was like, wow, that is brutal insults.
That is brutal.
It's brutal.
Yeah. Imagine that as like a ICD-10 code. Socially uninhibited individual.
Yeah.
I should see if it's one.
See if it's on there.
Yeah.
And these changes were noted immediately after the injury. So no time passed. Before, he was normal. Blast shoved the rod up through his skull. It was removed. And immediately after, he experienced behavioral changes.
Wow.
And so his physician, Dr. John Harlow, was totally attached to his case.
Absolutely.
As you can imagine, you know.
He's like, got the coolest case of the 1800s.
Right, exactly.
Yeah.
He's the shit. He later wrote in a paper, which he published after Gage's death, previous to his injury, although untrained in the schools, he possessed a well-balanced mind and was looked upon by those who knew him as a shrewd, smart businessman, very energetic and persistent in executing all his plans of operation. And I'm like, wow, that's the most boring compliment ever.
Yeah.
In this regard, his mind was radically changed so decidedly that his friends and acquaintances said he was no longer Gage.
Man, that's hard.
It's
right?
sad.
It's super sad.
Yeah. It's like you don't even recognize him anymore, and he doesn't really recognize or care to recognize you either.
No, not at all.
When Gage died in the 60s, so he wasn't that old.
Oh, he went into status epilepticus and died.
Yes.
Wow.
Yeah. And if you don't know what that is, do you care to explain?
Yeah. So a seizure lasting longer than 5 minutes or multiple seizures within that 5-minute timeline without full recovery in between, meaning when people have seizures, they have something called a post-ictal state. And if they don't fully recover from that post-ictal state before going into another seizure, they go into status epilepticus.
Yeah. And it's really, really dangerous and it requires immediate treatment to prevent brain damage or death in this case.
Yeah. And they didn't have benzos back in
They weren't pushing any
1860.
1860, yeah. And so he died, and Dr. Harlow took this opportunity to exhume his skull and tamping iron, both, because Gage kept the rod wherever he went as his constant companion. He traveled the United States all over, coast to coast, and he always had the rod with him. Like he couldn't give it up. It was part of him, kind of.
I mean, it makes sense. Like you had this life before and you had this life after, right? And like this was the thing that changed your life.
Yeah, the deciding factor.
Yeah.
And so Harlow wrote a paper on the subject and then donated the skull and rod to Harvard Medical School's Warren Anatomical Museum, where it still is.
Oh, really?
Yeah.
Wow.
You know, go look at it.
Yeah, just a little fun family trip.
Family trip. Buy me a copy. Support us for our family trip. Okay, so that case really kind of described how people in a traumatic injury that hit the frontal lobe could then change behavior. And what we're going to see now is all of these neuroscientists and physicians really take it and run with it.
Yeah.
And where that begins is with Dr. Burkhardt. Graduated with his medical degree in 1860 and soon after began practicing medicine as a general physician.
Yeah.
Okay. Not a neuroscientist.
No, but they didn't really have residency programs and all of that at this time. Let's not be too harsh, okay?
Okay. So after time spent recovering from, his tuberculosis diagnosis, because it was the 60s, and it was all the rage. He became interested and decided to specialize in disease of the nervous system. And he wrote multiple papers where he argued the internal medicine is linked to psychiatry and looked for fluctuations in temperature, blood pressure, pulse rate that could be associated with mental illness.
Okay.
So trying to find ways where the body function is connected to people's
Your vitals.
mental illness.
Yeah.
And so he also believed that oxygen consumption and blood circulation may be related to psychiatric disorders. Right?
Yeah.
We can see the train of thought happening throughout time. And then in 1882, he became the supervisor of, I'm not going to say this correctly. I definitely should have looked this up.
An asylum.
Preffinger Asylum could be correct. We'll have to look that up later. And in 1888, began experimenting on the brains of 6 patients despite having no previous experience in surgery.
Wild.
So he becomes a supervisor in this asylum and says, you know what I could do? I could just practice on these people.
Because they have no one fighting for them.
Yeah. They're all schizophrenics. Which, you know, most of these cases, people generally are either diagnosed with like melancholy, aka depression, or schizophrenia. There's no like borderline personality disorder.
Schizotypal, schizoaffective, like the different, we don't have all the personality disorders yet.
Yeah, so it's either this or that.
Yeah.
And so when people are like, oh, well, there were 6 schizophrenia patients, I'm like, maybe. You know?
Yeah.
Who knows if they were actually meeting the criteria that we use today.
Absolutely. And probably not, right? Because, I mean, you think about today, how long it takes to actually get formal diagnoses of this, right? We have to rule out that there's no like drug or alcohol. There's no medical cause. And then these patients still struggle to get these diagnoses most of the time.
Yeah. It's not like they're pulling out their pocket DSM-5, like, oh, yep, they're meeting all of the criteria.
And this guy's like schizophrenia for everyone.
You get schizophrenia. Which is also so terrifying. Schizophrenia is so scary.
Yeah.
And I think maybe, it depends, I don't know personally, but like I think they are the population that is going to be willing to look for any kind of relief
to help them
because it's so frightening to experience.
They're at their wits' end. Their family members who are trying to take care of them are at their wits' end. They've tried everything. They're looking to have like their own quality of life. Yeah, I completely agree. You go back to, do these people have decision-making capacity? A. B, if they do or don't, is that being respected?
Right. Who knows?
You know, like in this guy who doesn't have any previous experience in surgery, just deciding, you think someone was like, yeah, doc, you're the one. Let's try it.
Yeah.
Not a chance.
Yeah. And so the idea was that he was going to remove violent aggression and agitation from removing specific portions of the brain. And what happened after he removed these portions of the brain, most patients became approachable and easier to handle, but 2 died. And all
2 out of 6, so a third.
Yeah,
a third.
2 of them died, and then all suffered aphasia or seizures.
Wow.
Moving forward.
Yeah.
And what we're going to see later as well is initially people saw, quote unquote, a lot of improvement in people's behaviors because they were less aggressive, right? But in the long run, it didn't actually do what it was intended to do. I think more so it was society's inability and unwillingness to work with aggressive patients because they're like, I just don't want to deal with this. Right? It was that unwillingness that led to these extreme measures.
Yeah. And you just think that makes medical professionals sound like awful people, right?
Yeah.
But like even nowadays, we get physically, verbally, mentally, emotionally abused by patients more often than I think most people realize.
Yeah.
And we have safety measures now where we say this isn't safe for the patients, not safe for us. We're going to chemically help them, help us until we can come up with a more long-term plan. They don't have these options, right?
Yeah.
So someone's aggressive and they're just being abused over and over. I'm not saying it makes it right for them to like go into brain surgery and become completely different people, but also like understanding it's hard to take care of these people. And it's hard to show up to work or show up to take care of your son, your daughter, whoever every day and not know what sort of injury you're going to get, you know? And it's not the patient's fault. Like they're oftentimes hearing these command hallucinations, right? That are telling them to do these things.
Yep.
They don't know the difference. Like nobody's told them those voices aren't real and how to talk through them and all of those things. Oh God, that's so hard.
Psychotherapy is not a thing yet.
Not a thing. Also, meds are not a thing.
Meds are not a thing yet. So all they have are And we'll get into a little bit more are like physical restraints and then this psychosurgery, this idea of removing portions that they know will make their behavior different and more like docile. So you're not
happy.
You're not, you're just docile.
Yeah.
You're like there,
Yeah.
existing. Right. And so really the medical congress did not respond well to his research. And eventually he gave up on psychosurgery. He still studied mental illness and the connection to overall bodily anatomy and things. But overall, he gave up the surgery portion, which is good because his record was not stellar.
Yeah.
So that occurred in 82. Okay. And now we're going to jump to 1935, where there was the Second International Neurological Congress held in London. This could be a TV show. You watch some of these shows and you're like, there's no way that would happen. No, all these people were at the same congress that was held in London. And then from this congress, they go off and do wild things. Okay. They all attended. Everybody was here. This was the center point of where we go. And so here at the Congress, there was an American physiologist named Dr. John Fulton who presented an experiment with 2 chimpanzees that were generally defined as aggressive. Okay. And they each had bilateral restrictions of the prefrontal cortex. Okay. And so the animals became devoid of emotional expression and were no longer capable of frustrational behavior, usually seen in these animals.
But were they capable of happy behavior? You know, like, yeah.
The behavioral changes were overall noted, but the full implications were not.
Yeah.
So,
yeah. They're like, when? So I feel like we should say that back in this time, there's like no FDA approval for these sorts of, FDA might not be the right answer for this because it's not an implantable device. But like there's no approval for these surgeries, right? And then when I was doing research for another episode coming up, the reports that these people turned in were like, it is promising. There have been good results, right? There's no p-value. There's no survey that has these like objective findings. It's all super subjective. And so they choose what to report on and what to not report on. Hence, the full implications were not defined.
Realized,
And it's like, no, they were probably realized, but like you were like, ooh, a win.
Yeah.
Let's talk
we're
about
trending in the right direction.
Precisely.
Yeah.
Yeah.
So at the same Congress, there was Dr. Antonio Moniz and Dr. Almeida Lima. I should really like
give yourself a little thing beside it that has
pronunciation guide. Man, this is episode 2. Stay with us, folks. We'll get there. They were a Portuguese neuroscientist and they heard about the chimpanzee experimentation and they wanted to see if that would essentially work on people for psychiatric illness. And so in the 1930s, they argued that the aberrant circuits in the prefrontal cortex are responsible for mental disease and that the partial excision of these circuits can alleviate the symptoms of mental illness partially or entirely.
Yeah.
And in 1935, they performed their first psychosurgery, which involved drilling a hole in the patient's skull and infusing alcohol into the lesion.
Alcohol.
And this becomes really popular.
Okay.
The following year, they performed an additional 20 of these operations.
Wow.
On 20 different patients.
Did they say why alcohol? Like, were they using it for the
degenerative properties?
Interesting. They just thought pouring it straight on would.
Well, they inject it.
Okay.
Specifically into portions of the brain.
Yeah. Okay.
Yeah. In other operations, he severed the fibrous tracts between the thalamus and the frontal lobe using a retractable wire called a ludocome, which he invented himself. The procedure was called a leucotomy and became widely known later as a lobotomy when we get to our later characters who changed the name. So started with injecting alcohol and the idea was to create more white matter in the brain.
Yeah.
And so you're severing connections, you're degenerating this portion of the brain and then increasing white matter in the brain.
Okay.
Later on, just severing the tracts themselves.
Yeah.
And interestingly enough, this is just a little not so fun fact. In 1939, while working in his office, Moniz is shot multiple times by a patient. He survives, but is left partially paralyzed.
By a patient that he caused
Unclear.
Some prefrontal cortex issues with, and now we're seeing the effects of this. Did he report that into this Congress?
Yeah, right. In 1949, he actually received a Nobel Prize for his pioneering work on frontal leucotomy, in which the white matter connections between the prefrontal cortex and the thalamus were sectioned and intended to alleviate severe mental illness, including depression and schizophrenia in long-term hospitalized patients. And he was nominated by Dr. Walter Freeman, who was also at this Congress in 1935, who was a total asshole.
The name sounds super familiar.
Yeah,
there's something I'm supposed to know about him in the history of medicine.
And you'll know.
Okay.
Because he is something.
Okay.
He's a character.
I'm excited.
Yeah, I actually first heard about him on Morbid.
Yeah.
And they do like a 2-part episode on just the true crime portion of him.
Wow.
And some of his early, he's wild. He's
excited. There's something, like I said, he invented something I'm supposed to know about from my studies.
He invented it all right. Okay, so let's set the stage.
The 20th century.
Yep. Which is
last century, just so we're all clear. This is the
century we were born in.
Okay.
Which is terrifying because a lot of this stuff happened. It doesn't even feel like that long ago.
When our grandparents were alive.
Yeah.
Yeah.
They could have had a lobotomy.
Yeah. I mean, some of it. Yeah, absolutely.
Yeah. Right. And so we always are, oh, that was so long ago. And every picture I see is in black and white. And then I'm like, yeah, that's on purpose.
Yeah.
To make it feel like it was a long time ago, but it wasn't really. So let's set the stage for mental illness and the general early 20th century. Like what's happening when it comes to mental illness and the population of these patients. Reminder that psychotropic drugs, not available.
Yeah.
Till the 1950s.
And I'm sure those ones sucked. But yes, 1950s.
Yeah, 1950s. Psychotherapy and psychoanalysis, not available to most patients who suffered from psychiatric disorders until much later in the century as well. Yeah, you don't have providers that are trained in this that can readily provide it to these patients on a mass scale. There was also an increasing number of mentally ill patients for whom no effective treatment was available except for long-term hospitalization and confinement.
Yeah.
And that was really the 2 options, right? You're going to stay in this hospital for the rest of your life.
Have no quality of life whatsoever, right?
Nope. And if you act out, you're going to be confined in some way. And that could have been with physical restraints as like straitjackets, isolation in padded cells, things like that. That's what's going on here, right? You just think about isolation in general and how that affects
the mind. Yeah.
The mind,
it doesn't make people better. Let's just say that.
And I would argue like being in an overcrowded hospital and as someone who has worked in the mental health world and worked in psychiatric hospitals before. A lot of people go in there to get better, but the space does not allow for them to get better. Even today, watching people come in and
they have hope when they come in.
Yeah. And then they leave or they get worse when they're there because there's other people there that are also suffering and violence is done onto them and there's fights and people are restrained constantly and
we don't have good ratios for them to actually get the care and individuality that they need in this.
Yeah, and I'm talking about when I worked at one institution, the ratio was 1 to 10. So me for 10 teenagers, and that is a lot.
Yeah.
If you think about if a fight breaks out, if somebody does something and needs medical attention, the nurses aren't on the unit. You're alone on the unit. And then you're talking about this, and the ratios must have been 1 to 100.
Probably. Yeah.
I mean, what are the chances you're getting people and kind, empathetic
that are going into this field for the right reason?
Yeah. You're just not able to take care of that many people.
No.
And so in a report from 1937, it was stated that in the United States, there were more than 450,000 patients institutionalized in 477 asylums, with nearly 1/2 of them hospitalized for 5 years or longer.
So what's that math? 1,000 per?
Almost
1,000 per an asylum?
Yeah, and some were much larger than others. So
yeah, but on average, I mean, you just imagine 1,000 people.
There was multiple, and I think I'm going to, down here I'm going to talk about it, but the 2 largest hospitals each had a census that exceeded 16,000 patients. Could you imagine having 16,000 patients?
No.
And there's no way that was staffed appropriately.
Absolutely not. And there's no way you even know the patient's name.
Right.
Right? Like, no.
And they're not in separate rooms.
No.
They're in
We don't have 16,000 rooms in this hospital.
Right.
Yeah.
So they're probably in one large room in cots.
Yeah.
And so why why is this happening? The ever-increasing population of public psychiatric hospitals from 1900 to 1955 was largely due to these facilities becoming the destination for those with syphilis and for the elderly.
Okay, so I feel like we need to take a step back. I know syphilis sounds crazy, but as we get through the stages of syphilis and it becomes untreated, we do see a psychiatric component to syphilis. So just for those that don't know, it might be like, oh, why are we putting someone with syphilis in here? But like, we don't have treatment for it at this time. I'm assuming. I don't know off the top of my head, if we're all being honest with each other. And so these people are getting through, and they're hitting, I think it's the fourth where we start seeing the effects on the brain. Where else are they going to go?
Exactly. It does put it in perspective of half of these people are like suffering from syphilis, or they're old, right? Yeah. And then everybody else is being diagnosed with schizophrenia, melancholy, having the emotional breakdown because you're a housewife, and and being sent here just because. Yeah. Right? Probably the amount of people that were actually ill
and needed treatment,
right, were very small. But the population was so large that these people are getting lost.
Absolutely.
You're probably like, why are there so many elderly people being sent to these institutions? Well, we went from becoming a farming country. Everybody was a farmer. Everybody lived on the homestead. Generations and generations of the family were in the same house and the same property. Your great grandmother also lived there and was being taken care of by the family. Yeah. That's what was happening before.
Yeah.
Right. And then industrial society comes. The world wars come, and the multi-generational family dissolved, essentially, right? People are working in factories, we're building airplanes, we're doing all of this stuff, and no longer just living on the homestead. We're living in cities more so, and so there's not room.
Multi-generational homes anymore.
Right.
Yeah.
Grandparents, there's no room.
Yeah.
You're starting to get a little old, you're starting to get a little
difficult to take care of.
Yeah, let's send you off to the asylum.
Yeah. I hear it's a good place.
Yeah, I hear it's great. The change essentially left no one to care for elderly family members, who unfortunately then became the responsibility of the state. And then, like I said...
let's make it very clear, this is still happening.
Yeah, this still happens.
This still happens all the time. All the time. I know it's sad, but the amount of times somebody comes to the emergency room and the diagnosis is failure to thrive, aka can't take care of themselves anymore, family is nowhere to be found, or at their wits' end, or they don't literally have the means to take care of them, which is so sad.
Yeah.
And they're like, we got to go somewhere. And I'm like, oh, tonight?
Yeah.
This happens all the time.
Yeah, it does. It happens not only with elderly as well. It happens with kids and adults as well. The amount of kids that I saw dropped off in the emergency room because parents were just
at their wits'
ends, couldn't handle, quote unquote, handle them anymore. And so they were like, take them.
Yeah.
Put them on a hold and then send them to a long-term facility somewhere. And I'm not saying that there are not times when that is the best course of action for the individual. It's just extremely sad to see it on a large scale.
Yeah.
Day after day.
I agree.
And so these hospitals were extremely overcrowded. They were never able to keep up with the needs of their patients. The hospitals went from awful to appalling when their workforce was pulled away to meet the manpowers of World War II.
Yeah.
You have half the population fighting overseas, essentially, the older population being sent into asylums. And then you have everybody else.
I mean, still in some ways fighting for the war from the home front, right?
Yeah.
Getting weaponry and everything else ready to be sent.
Yeah, building for the war, providing for the war. And so you have women entering the workforce and really trying to hold down the positions as men are drafted and go overseas. And then you have who is going to take care of all of these people in the asylums and in these institutions. And that's, again, where you see the egregious ratios and really poor environment that these patients are living in. And the cost of having this system back then, today, would have cost well over $24 billion.
Absolutely, it would.
Yeah.
Yeah.
It's an expensive weight on the government because the government is providing these services, though they're not good services and they're not solving the problem, but they were the solution at the time. And so mid-30s, ineffectual treatments, hospital overcrowding, and so Moniz and Lima begin to carry out their work in Lisbon, Portugal. Then in the United States, Dr. James Watts, a neurosurgeon at George Washington University, begins collaborating with neurologist and neuropathologist Dr. Walter Freeman in developing the transorbital lobotomy by the early 1940s.
All right. So now we're diving deep into the actual lobotomy world.
Right.
Set the stage. We're ready.
Right. We've set the awful
we're
stage.
in crisis.
We're in crisis, right? There's no meds. There's
people
no
aren't being
therapy.
cared for. Yeah.
Like ratios are bad. People are fighting in the war and then coming back. And
they're also traumatized.
They're also suffering. So it's not good. We're in a mental health crisis, if you will. Watson Freeman performed the first frontal lobotomy in the U.S. in 1936, so a year after that conference.
So 90 years ago. Let's set the stage. Yeah.
Less than 100 years ago.
Yeah.
Yeah. Freeman, he came from a family with long roots in medicine. So your dad was a doctor, you should be a doctor kind of thing.
Yeah.
Everybody's a doctor. Even though Freeman made multiple discoveries within the psychological world, it was his personal beliefs and obsession that created the dark history of the lobotomy. He was very in on practicing on cadavers and stealing cadavers and...
Cadavers as in dead?
Mm-hmm.
Okay. I mean, at least he started there. The other guy had no history in surgery and just said, let's go for it.
Yeah. This was a quote that he had about mental hospitals in general. A rather weird mix of fear, disgust, and shame. I looked around me at the hundreds of patients and thought, what a waste of manpower and woman power.
Wow.
So he's awesome. Yeah. With his knowledge of neuropathology, he modified the ludicome and created a better, precise method in order to target specific frontal lobe/thalamus tracts. So patients with affective disorders had their leucotomy more anteriorly.
Okay.
And then those who suffered more severe schizophrenic symptoms, the lobotomy was more posterior. So, 1939, Freeman performs the first ever prefrontal lobotomy in the United States. His patient was Alice Hood Hammett, a housewife from Topeka, Kansas.
Interesting. It's a housewife first.
Mm-hmm.
Yeah.
Yep.
Yeah. Okay.
We may get more into these people and these stories later on in a cadaver file, but basically melancholy, being a housewife in Topeka, Kansas.
Yeah. Topeka, Kansas.
Yeah. And actually, there's a lot of housewives that he operates on.
This makes sense because when there was that call to Congress, I think it was in the 1960s, they were saying that they were using it on housewives with ADHD children.
Mm-hmm.
Yeah. And that's what a lot of these lobotomies, later on surgeries, were being used for.
Yeah, I think it's a classic case of a lot of the population was overseas fighting a war and then came back and found that women were independent and in the workforce and had opinions. And they were like, whoa, you are agitated.
Agitated.
Or, wow, you're melancholy because I'm not letting you do anything or leave the house.
Yeah.
Because I'm pushing you back into the mundane housewife work. It's just not for everybody. In 1942, they published the first edition of their report that stated out of 200 patients, 63% improved, 23% had no improvement, and 14% worsened or succumbed to their surgery.
That's a significant amount.
That's a lot.
14%. Wow.
Yeah. Only 63% so-called improved, but we'll find later on that improvement is subjective.
Yeah.
And then the Journal of American Medical Association published an editorial supporting the basis for the procedure and the indications for lobotomies. So now you have your official medical journal saying, this is the way.
Yeah.
Like, look at these great stats. And that was just not the actual case. So Freeman originally had used the alcohol injections in some of his lobotomies, but he modified the procedure by using a modified ice pick instrument to traverse the roof of the orbit and enter the base of the skull.
Yeah. So when I was doing a brief overview, the ice pick just seems absolutely barbaric. I mean, it's not like a real ice pick, right? But it...
I mean, he did practice.
Yeah.
That's how he came up with the idea is he was practicing on a grapefruit in his house. It was an ice pick from his freezer that he originally did this with. The operation was frequently done with local anesthesia or the sedation following electroconvulsive therapy. So get electroconvulsive therapy and you pass out and they do the lobotomy.
Terrifying.
Yeah, right? For this surgery, so we haven't gotten to his updated surgery, which he inserts the orbital through the eye.
Yeah.
This is still going through the skull.
Yeah.
Right? Okay. So at this time, the was inserted to a depth of 7 centimeters at the base of the frontal lobes and swept 15 degrees laterally.
Okay.
Which sounds even worse when you put it in like the scientific.
How big it is?
Insert, no, like, yeah, like insert here and then sweep from here to here. Like, ugh.
Yeah.
I think I'm starting to get a headache thinking about it. In 1945, he began experimenting a new way of doing the lobotomy after hearing about a doctor in Italy who accessed the brain through the eye sockets. So now this is where you get your classic ice pick lobotomy through the eye.
Yeah.
Right? Freeman began experimenting in his own kitchen with an ice pick and grapefruit and eventually on cadavers.
Where is he getting all these cadavers?
Sometimes you have to get your own.
Yeah, I'm concerned.
Yeah.
Yeah, okay.
Anyways, yeah, it's disturbing, to say the least. With this new procedure, Freeman would be able to allow for the procedure to be carried out in state hospitals without the need of an operating room, surgeon, or anesthesia.
Absolutely. So let's just take an ice pick through the orbit into someone's frontal lobe with no anesthesia, not in an operating room, nada.
Yep.
Fantastic plan.
Yeah, and he was really into doing this without gloves.
I will say, though, I worked previously with a surgeon who is still practicing. And when he graduated med school, so he's still practicing alive, right? When he graduated med school, they thought blood was sterile.
Yeah.
So just like put that into perspective, that there are people that are actively practicing medicine who have obviously learned since then that it's not.
Yeah.
But it sounds crazy, but who needs gloves when we don't understand any sort of sterility or bacteria or anything like that at this point?
They understood it with him.
Yeah.
Later on, his partner would leave him because of his unsterile.
Oh, good. Okay.
Yeah.
So one of these guys isn't as bad as the other.
Yeah. Right. So in what became known as the transorbital lobotomy that we know today, procedure included lifting the upper eyelid and placing the point of a thin surgical instrument, often called the orbitoclast, under the eyelid and against the top of the eye socket. Okay. A mallet was used to drive the orbitoclast through the thin layer of bone along the plane of the bridge of the nose around 15 degrees towards the interhemispherical fissure. The orbitoclast was malleted 5 centimeters into the frontal lobe and then pivoted 40 degrees at the orbit perforation, so the tip cut towards the nose.
Yeah.
Then returned to the neutral position, sent 2 centimeters into the brain, cutting site to site at 28 degrees. In more radical versions, deeper cuts were also done. That's really deep.
Yeah, super deep. And like, it's not like they're using 3D model MRI like we have for some of the stuff that we'll get into next week, where they know exactly where to go through to not hit anything. Like they don't have any imaging of this person's brain. They're just going for it.
They're really like, okay, you got your electric shock therapy. Come on in. You're a little
woozy.
You're a little woozy. You're a little out of it. Let me just pop this in here.
Yep.
Swish it around.
Yeah.
You know, while 5 people are watching at the same time and nobody is sterile or we're not doing.
Nah, who needs that?
Yeah. And so Freeman hoped that physicians would use this simple technique to treat hospitalized patients widely.
Okay.
In 1946, he performs the first transorbital lobotomy in the United States on a 29-year-old housewife named Sally Ellen in his Washington, D.C. office. Another housewife. 29.
Crazy.
Right? In 1949 was the peak year for lobotomies in the U.S. 5,074 procedures were undertaken. In 1950, Watts expressed disapproval with the transorbital procedure, and the two eventually break their long-term partnership. It was mostly due because he thought it was barbaric. He did not agree with the operation at all.
Glad he finally figured this out.
Yeah, and he didn't like that Freeman was doing these procedures unsterile. He literally would like eat a sandwich and then walk into a room and do them.
Yeah.
Without washing his hands. Or putting gloves on, or anything.
Yeah.
So then Freeman kind of barnstorms the nation's state hospitals performing and teaching transorbital lobotomy. By 1951, over 18,000 individuals have been lobotomized in the U.S., and an estimated 40% of Freeman's patients were gay men lobotomized to change their sexual orientation.
Perfect. And I wonder if that worked.
Yeah.
Yeah. Crazy.
I guess if you can't think
you
and
don't
have a personality, you can't express being gay. I don't know.
Oh
That's
my God.
It's just so awful.
Yeah.
In 1952, Freeman performed 228 transorbital lobotomies in a 2-week period in West Virginia for a state-sponsored lobotomy project dubbed Operation Ice Pick.
What a perfect name. You know, I hear that and I'm like, sign me up.
Yeah, people were like bringing in their housewives and their children and
Yeah.
being like, lobotomize them. This is
Yes.
great. Yeah. In 1952, an era of widespread hospital psychosurgery fades away with the introduction of Thorazine,
Yes.
and Freeman moves to California to set up office. So he's moving west as people are coming up with medications and start using them on the East Coast, and it's moving west. And he's like, oh, I'm going to go west, you know,
I'm going to go as far west as I can
and keep
to
doing.
practice as long as I can.
Yeah.
Yeah.
In the 1960s, Freeman lobotomizes Howard Doley, age 12, at Doctors General Hospital in San Jose, California.
12 years old.
Yep.
No way.
Yeah. There's
Holy shit.
like, what possible reason could you have to lobotomize a 12-year-old?
There isn't one. There isn't one. Okay, he's a badass kid. Figure something else out. Like,
He was slightly disrespectful.
12 years
energy.
old. That is wild.
Yeah. In 1967, he performs his last transorbital lobotomy on a longtime patient, Helen Mortensen. It's her third lobotomy by him. She dies from a brain hemorrhage following the procedure, and Freeman is then banned from operating.
I guess I'm a little confused. Like, why are we doing 3 lobotomies if we've already severed that connection?
More.
We're doing more. We're severing more.
Yeah. Lots of people went back for more than one. Yeah.
Man. Okay. You know, maybe if it didn't work the first time, try again.
Yeah. So in 1968, he retires after he's banned from operating and embarks on a cross-country follow-up study on his lobotomy patients, which I'd take it with a grain of salt because it's his own study on his own patients. Right?
Yes. Talk about a
bias.
Yes.
Yeah. In a follow-up paper based on Freeman's patients, which was a quote-unquote long-term follow-up, some were 4 years after the lobotomy, some were 30 years after the lobotomy. This was based on 707 schizophrenic patients, but as I said, diagnosing schizophrenia was not a perfect,
no.
Like, it's still not a perfect science, and it wasn't.
Yeah. But like, if you get the diagnosis, are you able to do the lobotomy sooner? Like, is he just like literally handing out schizophrenia diagnoses?
Yeah.
Ugh.
Yeah. And so in this report, 73 were still hospitalized or at home in a state of idle dependency.
Of course they were.
Yep. So
yeah. So like, how many people do you think looked back and they like caretakers say that like actually gave Freeman permission to do this to their 12-year-old son?
Yep.
And they looked up and they were like, holy shit, I'd rather the hyperactive kid that was eventually going to grow out of it, but is just 12 years old and bored, than I have to take care of this kid for the rest of my life because they're fully dependent on me at this point.
Yep.
Ugh.
Yeah. So that's kind of where we end lobotomies. Because after this, with the introduction of drugs on the scene, you know, finally pharmaceuticals are coming in and we're like, okay, this is a much better way. Chemical restraint and overall chemical treatment is a much safer, humane way to go about treating these patients. Then also therapy, psychoanalytics and psychotherapy become widespread. More people are trained. And then eventually institutions like the ones you mentioned earlier are closed.
Yeah.
And people
look up and they say, holy shit, we don't have the staffing for this. You know what we should do? Close it.
Yeah. And so those are closed and people are moved back on to the streets or trying to live with family. And really, we don't see an improvement in mental health until like Medicaid, when people have more access to the healthcare that they need.
Wow. Man, that's crazy.
Yeah. And so I really think it's important to notice that the reason lobotomies became the number one most popular operation to treat quote unquote mentally ill patients was because society did not know what to do with people who were old, who were angry, who were sad, who were aggressive. From time to time, and families didn't want to deal with it anymore.
It's so sad that like these people that have no way of really standing up for themselves or who get experimented on.
Yeah.
And I know we're going to see that so many times through history, but like for mentally ill, I think it always makes me the saddest because like, oh,
yeah.
God.
Yeah.
Yeah. Wow. All right, my piece, medicine today. So most of the medicine today is going to actually go in next week's episode because we start getting into like ablative therapies.
Mm-hmm.
We get into deep brain stimulation, comes from these ablative therapies and the experiments that they're doing inside of these people's brains while they're going in to ablate them. It's a wild time in neurosurgery. And then we get into deep brain stimulation and electric shock therapy. And it's just such a big topic. We just gave it its own episode.
Yeah.
Yeah. Because there's so much to know in that. But we'll start with some anatomy just to understand a little bit of the brain and understand like why the frontal lobe worked worked is a strong word. The frontal lobe had such severe consequences when we were doing it. So parts of the brain, you have your cerebrum, your brainstem, and then the cerebellum. And so the cerebrum is what initiates and coordinates your movement, right? It regulates temperature, speech, judgment, thinking, and reasoning, problem solving, emotions, and learning. And you're going to find in these parts of the brain that there's going to be a lot of overlap. If only one part of the brain helped with thinking, judgment, reasoning, if that ever got injured in a stroke patient, say nowadays, we wouldn't see them have any of these anymore. And so that's why we have that the brain has multiple of these.
It's got backups.
Backups, precisely.
Yeah.
So cerebrum is what most people think about when they think of the brain. It's divided into that right and left hemispheres.
Mm-hmm.
And then it has the 4 different lobes, which we're going to get into in a minute. Next is the brainstem, and that's what connects the cerebrum to the spinal cord. And this is kind of what we were talking about, last week when we were talking about brainstem herniation and that Cushing's triad. This is the bad shit. Okay. Mm-hmm. So 3 parts of the brainstem. There's the midbrain, which is the relay center for lots of things, motor function, vision, hearing, alertness. And then it also processes sensory signals. So vision, taste, touch, those type of things. And then you have the pons, which is responsible for tear and saliva production, head and face sensations, and then motor control of the eyes, face, mouth, and then also hearing and equilibrium. Then you have the medulla. So the medulla is responsible for essentially our vital signs and vital functions of life. So you have heart rate, breathing, blood flow, oxygen, carbon dioxide levels. And then it has some reflexive activities such as like sneezing, vomiting, coughing, things like that. Essentially, when we were seeing the heart rate changes and the breathing changes in the hemorrhages from last week in the Cushing's triad, this is an effect of that medulla directly. Mm-hmm. Then we have the cerebellum. That is fine-tuning voluntary muscle movements. And so initially we have these voluntary muscle movements, but how do we make them not jerky? How do we make them smooth, exactly what we want them to be? And then also maintain posture, balance, and equilibrium. Equilibrium's a big thing in our brain, okay? It appreciates it. There are some newer studies that are showing, this might have some roles in thought, emotions, social behavior, but going to take a lot more studies. And then they're also thinking, is there a possible role in this part of the brain with schizophrenia, addiction, autism? So exciting research to come on all of that. Okay, so the lobes of the cerebrum and its functions. So frontal lobe, hence where we have a lot of our frontal lobotomies.
Yep.
It is responsible for personality characteristics. So that's why in that like famous case of Gage, Phineas Gage, that frontal lobe was severed and his personality completely changed.
Yep.
Decision making, impulse control, planning, and voluntary movement. And this is what everyone talks about. Like, it's not fully developed until it's 25 years old. Don't get married until you're 25. Don't make big life decisions until you're 25.
Yeah.
Because it is still forming. So that's why this frontal lobe lobotomy had such drastic changes on these patients. It's because this is our personality center, for lack of better words. So, but that's also why it worked on these patients, because if we're cutting off our impulses, they don't have them anymore. So even though it's responsible for impulse control, they're not having these awful personalities or these impulses gone, right? Isn't that crazy? Yeah. Crazy.
They're just sitting there, not doing anything.
Biggest part of this frontal lobe for those studying medicine is this is where Broca's area sits, and that's responsible for speech ability. Then you have your parietal lobe. So this is identifying objects, understanding spatial relationships and awareness, language, interpreting pain and touch, and proprioception. Biggest part of this area of the cerebrum is Wernicke's area, and it helps the brain understand spoken language. So what's interesting about this is in long-term alcoholics, we'll see something called Wernicke's aphasia, and they're able to talk to you, but they have what we call a word salad. So the speech isn't understood as it comes out. And so they're saying real words, but it's just not anything
coherent.
Meaningful. Precisely. Yeah. Then you have temporal, which is responsible for learning, memory, speech, music, rhythm, hearing. And then the occipital sits in the very back, and it's responsible for vision, which I think is interesting that vision obviously is here, but comes from way back here.
Yeah.
Right?
It is interesting. They like send those long wires of connections all the way back.
Yeah. All the way back.
Maybe it's a protection feature.
Maybe. Yeah. I don't know. I knew all this at one point, and then I said, whew, thank God I'm not going into neurosurgery.
And then you did a podcast.
And then I did a podcast, and I'm having to relearn so much of this. So modern day treatments, this, I'm not going to lie, this is kind of a cop out on this episode because there's so much to come in the next episode, but you already kind of talked about it. You know, we're starting with therapy for these patients. We have pharmacotherapy, which I could not convince myself to go through pharmacology in this podcast. I decided we are not doing that. I don't want to relearn everything. I don't want to explain it. This is fun, not a pharmacology podcast. But we know that the pharmacology is constantly evolving. But what I think is going to be interesting in that is, you know, we already know that if, say, I have depression and my father has depression, when we are starting patients on these medications, we say, what medication works for your father? Mm-hmm. And we're actually going to where most people now are putting you on that medication first, because we know that there is a genetic pipeline in depression, bipolar, schizophrenia, like all of these things, right? And so it'll be really interesting because there's works that are going to take years and years and years of studies figuring out why does this medication work for you. And it's not going to be used for like mainstay anxiety and depression, but it's going to be used for like treatment resistant. Why isn't this working? And we're going to like genetically test. And
instead of having to take
years and years to figure this out.
Yeah, to find the right med. And, you know, most of those meds don't really kick in until 6 weeks.
Yes.
And you don't see a difference. So you spend 6 weeks taking
and then you increase
medication.
it a little bit, see if it's going to work again.
Yep.
Yeah.
And you have the awful side effects, and then you got to start a new med because that one didn't work. Yeah. Now you can just say, oh, this has worked generationally for...
Precisely. It gives us a starting point, whereas before we're like, what's your favorite SSRI or SNRI? You know? Like, yeah. But then we also have neuromodulation that we're starting to use for this treatment-resistant patients. So brain stimulation is one of the biggest ones. And so there's electroconvulsive therapy, ECT, and this is actually gold standard for some things right now, which is crazy, specifically for catatonia associated with schizophrenia, mood disorders, and also non-psych disorders. So that's, to me, really cool that we have a gold standard treatment for these patients. There's also deep brain stimulation, which is particularly being used for like Parkinson's, essential tremor. We're going to get more into like those next week. But then we are under FDA trials right now for depression, OCD, schizophrenia for this deep brain stimulation. And then the one that I decided we'd talk about the most this week, because it's not really going to fall into next week, is this transcranial magnetic stimulation, which I actually had not heard of before. And so once again, used for treatment-resistant depression, PTSD, OCD, Tourette's, and then we're getting further along in FDA trials for other things. And so it's still in the early stages, but it has really promising studies so far, especially for refining some of these that aren't responding to medications quite as well and optimizing the medications or the therapy or anything else. It's not going to be used as of right now as like a
standalone treatment.
Yes, precisely. And so an electromagnetic coil gets placed against the scalp, and it gets placed in different areas of the scalp depending on what they think is wrong. And of course, this is being like very highly studied with MRI and figuring out which part of the brain is being affected for you personally. And then they're placing that coil in the correct spot, just against the scalp, like nothing. It's minimally invasive, right? There's no surgery, there's no cuts, there's nothing like that. And then it delivers these magnetic pulses. And when I was reading, I was like, what do you mean magnetic pulses? Like, what are we hooking this up to? And essentially, people are just flipping this coil on, off, on, off, on, off. And that's delivering the pulses. And they know that they're at the right strength of the pulse, like high enough electricity, because I believe it was the abductor pollicis brevis. I'm going to have this wrong and someone's going to correct me, but they're seeing finger twitches in a specific muscle. And that's when they know they have it high enough for these patients. And then it stimulates these nerve cells involved in this mood control and depression. And so it's really cool because it's very few side effects, whereas like ECT actually still has a lot of side effects because we're inducing these mini seizures of people like having severe seizures. But this TMS, they're like, you know, people that have a history of migraines and headaches, they might leave with a mild headache. The side effect profile of it's fantastic.
Interesting.
Yeah. And so I hadn't heard of this yet. I thought it was really exciting. But like I said, next week we're really going to dive into ablative surgery that came out of lobotomies, and then that ablative surgery and how they were just like testing impulses, electrical impulses in random areas of the brain, led to deep brain stimulation. And then how now we're kind of in this ECT and how that's also not been a great thing through time.
Yeah.
But yeah, so just we've come so far with medications. I think medications and therapy are the best for these patients, of course. But then it's also still sad because like we see patients all the time in the emergency room that are having these command hallucinations. And we typically, while we're waiting to get consults from telepsych, we'll put them on like a Zyprexa or something like that, just an oral Zyprexa, just to get them to feel safe in their environment, and they feel great. And you're like, I can discharge you on Zyprexa, but then like most of them are homeless or don't have insurance or don't have a way of like picking up this medication, and so they don't, right?
Yeah.
And then 2 weeks later they come back in with these command hallucinations or whatever else, or they're seeing people following them, and like it's sad because even though we have these, we're still stuck in we don't have long-term treatment for these patients that are continuously going to fall out of the therapy that they really need.
Right.
And I don't see that changing anytime soon.
No, not with our current system, and not with people's interest.
Yeah.
Not falling on, those underrepresented people.
Yeah.
It's kind of like if you don't see them, they don't exist.
Yeah, precisely.
Yeah. Which is just awful.
Yeah.
Okay.
So, ethics autopsy. Poor. Not ethical.
Not ethical.
Not ethical whatsoever. I've said it 100 times this episode, like it's the wrong people that are being tested on and treated, and a lot of them probably didn't have a way of like actually standing up for themselves, and that's really sad.
Yeah.
And so like the ethics behind all of this is just terrifying.
Yeah.
Yeah.
Yeah, and the fact that people were just institutionalized and then operated on, and it's all bad. And it's also bad because the people doing these operations probably didn't know the complete impact of the operation.
Yeah.
And so they were readily handing them out as the gold standard of like, this is what we're going to do, without being able to properly give the patients a disclaimer of what could happen.
Yeah. There's no risk benefit discussion before this.
Yeah.
Cut it or keep it.
I mean,
we're cutting the lobotomy.
Lobotomy, see you later. Belongs in the past. Let's not bring it back.
All right, friends, that is all for today. If you'd like to support us, you can follow us on Instagram or TikTok at _cadavers_lessons. You can donate to us at buymeacoffee.com/the_cadavers_lessons. You can listen mainly anywhere you get your podcasts. Yeah. So we're up on Spotify, Amazon, and Apple at this point. Like we said, main episodes dropping on Monday, and then case files, which this week I'm actually super excited for because there's so many historical cases with this, dropping on Fridays. And then the best way to support us is leaving a review, commenting, sharing our podcast on social media with your friends, with your family, anyone that you think might be interested. If you have an idea for an episode or a case or anything like that, you can always DM us on social media or leave it in a comment or, a review, and we'll keep an eye out on those and add it. We love diving into new things, and we have so much great stuff planned. As we've already given you a sneak peek of, next week we're talking about all things brain again. So we're continuing this segment.
The brain train,
and we're getting into electroconvulsive therapy, some ablative therapy, some deep brain stimulation as we get into more of the modern era of it. And I'm really excited because I was reading like FDA history, which I never thought I'd be excited about. And it's really interesting stuff. And I was telling B, it all comes from the making of the pacemaker, which is just crazy that the two
went from the heart to the brain.
Yeah.
Wild.
All right. Class is dismissed.
Stay safe.
Stay curious.
And don't try this at home.
Unless you have a bone saw. Bye, guys. Have a good week. This podcast is for educational and entertainment purposes only. We discuss the history of medicine, not your personal medical situation. Nothing you hear on this show should ever be taken as medical advice, diagnosis, or treatment. Some of the information discussed may be incorrect or become outdated over time. We do our best to stay current with medical knowledge, but medicine changes quickly. Additionally, because we do not work in every specific field we discuss, there may be times when we misspeak or misinterpret information. We're all human, and we're doing our best for the podcast. Every medical case is unique, and your health decisions should always be made in consultation with your own qualified healthcare professional. If you have any questions or concerns about your health, please reach out to a licensed provider who can give you guidance based on your individual needs.